Impact of conditional economic incentives and motivational interviewing on health outcomes of HIV adolescents in Anambra State, Nigeria, a cluster randomized trial. Worldwide, HIV adolescents have worse treatment outcomes. This has been attributed to their poor linkages to care, poor retention in care and poor adherence to antiretroviral therapy. Worse still, scarce operational service delivery interventions for HIV adolescents, especially are available for HIV adolescents, especially in sub-Saharan African countries, where almost 90% of HIV adolescents live. There is therefore need for effective and operational interventions to improve their health outcomes and reduce HIV transmission. This our study was informed by outcome of Kim et al. Systematic review, coupled with dwindling funding in HIV care. This study therefore evaluated the one-year impact of conditional economic incentives and motivational intervention in achieving undetectable viral load, which is our primary outcome, retention in HIV care, and adherence to antiretroviral therapy by HIV adolescents in Anambra State, Nigeria. The incentive scheme, which is a behavioral intervention, was informed by the micro and behavioral economic framework, which posits that non-adherence is due to reduced utility. Therefore, conditional economic incentives, which is given on achieving viral load suppression, will help to improve utility, thereby increasing adherence and retention in care. However, this is short-lived, and therefore the motivational intervention, which brings about an internalized behavioral change and will bring about a sustained increase in adherence and retention in care. Motivational intervention is conceptualized by self-determination theory. In this cluster randomized trial, 12 HIV treatment hospitals in Anambra State were stratified and randomized into the intervention and control arm. The intervention arm received the incentive scheme comprising of conditional economic incentives on achieving viral suppression, which was measured every 3 months during the intervention period, and attending to motivational intervention session during the monthly clinic visit. Sample size calculation was done using a web-based sample size calculator, considering a power of 80% and two-sided alpha value of 0.05. And after adjusting for clustering and for possible attrition, the sample size for each cluster was 23 subjects. Intention to treat analysis was conducted, and comparison between the intervention arm and control arm for dichotomous measurements was done using chi-square test and Fisher's exact test. Comparison for means of continuous measurement was carried out using independent t-test. Statistical significance was set at 0.05. Ethical approval for the study protocol was from Nnamdi Azikiwe University Teaching Hospital Ethics Committee, and the study was carried out in accordance with Helsinki Declaration on Ethical Guidelines from Medical Research involving human subjects. Consent to participate was in accordance with the national legislation. The trial was prospectively registered with Pan-African Clinical Trial Registry in February 2018 and study implemented according to the published protocol. A total of 246 participants were involved in the trial. There was no significant difference between the intervention and the control arm based on the number of subjects, the mean age of the subjects, and the gender of the subjects. There was massive transition to dolutegravir-based therapy in the course of the trial, causing a significant change in drug therapy. This therefore necessitated for effect of adjusting for regimen change on the proportion of subjects that achieved viral suppression. Compared to baseline, there was a 10.1% increase on the number of subjects that achieved viral suppression in the intervention arm, while the control arm had a 1.6% decrease. The number of subjects that had greater than 95% adherence remains significantly higher in the intervention arm. The number of subjects retained in care was higher in the intervention arm, though this was not statistically significant. Because of the regimen change, the increased drastic change in regimen change, we adjusted for the number of subjects with regimen change, and we found out that there was a 14.6% increase in the intervention arm and 5.7% increase in the control arm because of the regimen change. This, however, was not statistically significant. Now, comparing it with the number of all the subjects with undetectable viral load, there was no statistical difference between the two. This cluster randomized trial showed a positive virological outcome of the incentive scheme on the HIV adolescents at 12-month assessment. Similar impact was observed in a study by Foster et al. In 2014. This forms a useful intervention for consideration by policymakers and implementers in HIV care to bring about an improvement in health status of HIV adolescents and reduce HIV transmission. Major limitation was disruption in supply chain due to policy change. Thank you.